I'd like to begin by acknowledging the traditional owners of the land on which we meet today. I would also like to pay my respects to elders past and present. Hi everyone, it's Helene here again, second time this week, and we have Jade from the PHN also in the background. Welcome everybody to tonight's webinar and thank you for attending. I did have a quick look at the registration list before I came on, and it was pleasing to see we've got attendees from right across our whole Western region webinaring in tonight. Just make a note that the majority of our webinar events are recorded and freely available on our PHN YouTube Learn channel, as on the slide we've got there. And we do have a practice communique that we send out to practices fortnightly with valuable information, including an external calendar of events and internal calendar of events. For this evening's meeting, participants attending will be put on mute for the course of the meeting. Should you have any questions, please type them in the questions box and your questions will be addressed they'll actually be addressed at the end of Sonia's presentation tonight. All anonymous, there won't be any names mentioned. Our presenter for this evening is Dr. Sonia Davison, endocrinologist. Please make note of the West Vic PHN health pathway relating to this topic that is on the screen at the moment. I'll now hand over to Cara from our Health Pathway team and she'll speak on this slide and then we'll go directly to our presenter for this evening, Dr. Sonia Davison. Thanks, Cara. I will now hand over to you.
Thanks, Helene. So I'm Cara and I'm the Health Pathways Program Lead at West Vic PHN. Health Pathways, for those that aren't familiar, is an online clinical platform for primary care clinicians and it contains condition-based guidelines and local referral information. So the pathways are written by clinical editors in collaboration with specialists, subject matter experts, peak bodies and agencies according to best evidence and in consideration of the local context. On the slide on the screen is a sample of the pathways relevant to this evening's content, but we have now over 800 clinical referral and resource pathways available. We've worked closely with Jean Hales and local clinicians to first develop and since review the gynecology suite. The content is only available to clinicians in Western Victoria and the login details are on the slide and will also be provided in the chat and in a follow-up email. Thanks. I'll hand over now to Sonia. Thanks for your time.
Thank you so much for having me. It's always a delight and an honour to speak. And this is, you need to know about this topic. It's a common condition and you will be seeing it and you need to know what to do. And I'm just going to try and finesse those skills. And thank you for having me. And nice to see you all out there. So this is a real case. This is one of my ladies. The name, of course, is not real, but Miss Pcos. She's 20. And she comes to you for excess hair growth. She's worried about hair in the sideburn region, mustache, jawline, and the midline of the abdomen. She's also having some facial acne, which bothers her, and irregular cycles. Her last period was 4 months ago. And she's gained a fair amount of weight. 20 kilos in the last 2 years is a lot of kilos. And for someone who's 20, you don't want to keep that rate of weight gain up, do you? It would be bad. She used to fence 5 hours a week in secondary school and she lost that activity, and that's typically what we see in these girls. They sort of more active in their teenage years, that sort of the sports lessons at school get lost, their activity, they get a license and they become less mobile on their own feet and they tend to gain weight, and that can bring this condition to sort of prominence. Her weight was 95 kilograms with a BMI of 33. You saw that she had acne, hirsutism, and abdominal striae. And so you're thinking, well, how do I proceed? So this is really what we want to do. So the limitation here is it's been very difficult with Pcos because there's 3 different sets of criteria. And I'm just setting the stage here, and I'm going to try and clarify this. Because if you look on the left of the side, the NIH criteria said that to diagnose Pcos, you just needed both chronic anovulation and clinical or biochemical evidence of increased androgens. So on the right side of the slide, there's the androgen excess Pcos Society, who thought we should do it differently because there's a lot of debate between experts in this syndrome. They thought that you should have ovarian dysfunction and polycystic ovaries and the clinical or biochemical hyperandrogenism. But the Rotterdam criteria is probably the most widely accepted criteria in the middle, and that's a 2 out of 3 scenario. So you need 2 out of 3 of, and you can have 3 out of 3, of course, any evidence of chronic anovulation, and it is possible to have periods and not ovulate, so that's a tricky one, and clinical or biochemical hyperandrogenism, and also polycystic ovaries. So 2 out of 3 of those. You don't need to have all of them. And it's very interesting when you look at the different criteria. These are different sets of populations that have been studied in different countries. And you can see there, if you look at the different criteria, there's a wide variety of prevalence of Pcos using those criteria. So the NIH tends to underreport it. If you see the Australian study by March there at the top of that table, 9%. But using the Rotterdam, it's double at 18%, whereas the Androgen Excess Society would put it at 12%. So there's always a lot of controversy about Pcos, and I've always come to sort of grief sometimes when a gynecologist will say, this is Pcos, and I'll say, well, actually, that's not Pcos. And in the end, it's the clinical problems that matter and the problem that the woman presents with and getting that bit right. I think the label is not always helpful. So because there was a lot of debate about this, some Australian researchers got together an evidence-based guideline in 2018, and it is a very long guideline, but there's a nice summary, and they've tried to sort of get all the evidence together, and you can easily gain access to this on the Jean Hales website. There's an easy click away. So what is this syndrome? And we also think it's a pretty poorly named syndrome, but no one has been able to come up with a better answer for the name that everyone agrees on. So we're stuck with the name that I think we've had since 1935. But it's a hormonal problem in women affecting up to, well, some studies say 20%, but most say 8 to 13% of women of reproductive age. But sometimes you'll get a woman coming to you with excess hair growth at menopause, and you think, oh, well, actually, that lady probably had polycystic ovary syndrome throughout her reproductive life, and she's just presenting now. Some people think that even up to 70% of women with this syndrome remain undiagnosed, and we think it's probably a problem of insulin resistance, even though measuring the insulin, you might not find any problem with it. And the way that the insulin works on the ovaries means that there tends to be an overproduction of testosterone, which leads to the end result of the symptoms, which is why a woman in her reproductive years will come to you. She will come with symptoms. So there's a lot of variability in presentation. Irregular menstrual cycles, some will worry about, but many won't. Excess hair, many will worry about. Infertility, many women who want to conceive will absolutely worry about that, and that's a really good intervention point. If a woman wants to conceive, you can get a good health message across there, and also pregnancy complications. But the metabolic things are extremely important. The insulin resistance, metabolic syndrome, there's a higher likelihood of going on to type 2 diabetes, a bigger prevalence of obesity, and cardiovascular risk factors are prevalent at a much younger age than you'd want for or that you'd hope for. But there's also a lot of psychological issues, because if you've got a 20-year-old with Pcos, like Miss Pcos had, then you're labelling that person with a chronic disease. And their studies have shown that there's an increased incidence of anxiety, depression, and issues around body image. And it can go the other way around too. These women can therefore develop an eating disorder, and that can be an issue as well, because it can go the other way. So it's there's a lot of issues here with labelling someone of a young age with a chronic disease. So the Rotterdam diagnostic criteria, again, 2 out of these 3 ones, oligo or anovulation. It doesn't mean there's no periods, it just means they might be irregular, long time between periods, or periods that can occur, but it doesn't seem like they're ovulatory. The second one is clinical signs of hyperandrogenism. So that's acne, excess hair growth where you don't want hair, or scalp hair loss, or biochemical. So you may have one or the other. It's very interesting, especially in different subpopulations like Asian women. So biochemical evidence would be higher testosterone, DHEAS, those type of male type of hormones that we have as well. And polycystic ovaries on an ultrasound, but up to a third of women, normal women of reproductive age, will have polycystic ovaries on an ultrasound. So that's the trick. So some women will come along with an ultrasound report and say, oh, I've got polycystic ovarian syndrome. And you'll say, well, actually, you've got polycystic ovaries, but you don't fit the rest of that. So just be careful of getting polycystic ovaries on an ultrasound and labeling them as having the syndrome, because there's a whole lot of ramifications there. And the cysts on the ovaries tend to be in a string of pearls. I don't know if you remember that from medical school days. They tend to be on the around the peripheries of the ovaries, and there's a certain number there, and I'm going to go through that. So it's the evidence-based guidelines have really forced us to look at this very carefully, but they have given us a few more guidelines, which I think are a little bit harder to just remember off the top of your head. It was a clearer and easier story before. So irregular cycles are normal in the first year after puberty, and of course are normal in perimenopause, when periods are winding down towards menopause, which is typically mid-40s. But 1 to 3 years after the first period, less than 21 or more than 45 days is considered to be irregular. But within more than 3 years after menarche, less than 21 days or more than 35 days. And 35 days was what we used to quote. And I think that's really hard to remember and unnecessarily hard. So you'd be forgiven if you just went with the 21 days and the 35 days, because that's what we used to say. Or you can say less than 8 cycles per year or more than a 90-day cycle. But whatever happens, periods are irregular usually. And ovulatory dysfunction, as I said, may occur with regular cycles. And that is, I suppose you might see that if they're trying to conceive, they're having periods, but they're clearly not ovulating. And we can, of course, test for ovulation or do temperature readings, which will show if they're ovulating or not. So you can clearly diagnose these without any sort of advice here, but adults present with acne, alopecia, but some of my teenagers also present with scalp hair thinning and excess hair growth, typically sideburns, mustache, snail trail region, and adolescents can have that severe acne and will worry about excess hair growth. And you can see there that jawline or chin region, and we can do a lot for that, and that's never going to do anything for self-esteem, is it? And we need to help these people who are already struggling at that time of life with self-esteem issues anyway, just being a normal teenager or whatever. So the biochemical part of having high androgens, total testosterone can be high, doesn't have to be though, so that's the trick. The sex hormone binding globulin tends to be related to weight. So if you're of a higher weight, SHBG tends to be lower, and therefore your calculated free testosterone will be higher. And typically you might see a low SHBG or a high total or calculated free testosterone. If they are on the oral contraceptive pill, those assays, the levels will just be low, but very high levels, you need to be aware of those. If it really looks like a male level, then we need to think about an androgen secreting tumour, which aren't common, but you of course need to find it. And those women will tend to have a rapid scalp hair loss and virilization, and you need to just be aware, oh, this is happening quick and I don't think that's quite right. So these are the sort of levels that you would expect to see in a tumour. So a testosterone of maybe 5 to 7, whereas normal testosterone in a woman of reproductive age at peak, will be up to 2.5. So 7 is just pushing it there, and I would be looking at the ovaries. A DHEAS level of more than 20 we'd consider an adrenal tumour, so you'd want to look at the adrenals. And a level of between 11 and 20, you'd want to consider congenital adrenal hyperplasia, which is not uncommon. And a good screening test for that is the 17-hydroxyprogesterone, and that should be elevated if you're considering that syndrome, which can present in this age group and can look exactly like polycystic ovary syndrome. This is the typical ultrasound appearance with the string of pearls, those enlarged follicles that aren't ovulating and are just sort of sitting there. What we think is insulin resistance is happening. The higher insulin levels are working on the ovary to just make the follicles not respond properly and not develop to ovulation. And what we now say is, we used to say 12, more than 12 follicles was abnormal, but in recent years they've said a follicle number of 25 or more, or an ovarian volume of more than 10 mils is what you consider to be polycystic or enlarged, and that has changed. So we need to think when a woman's in front of us, what might be going on? Is this indeed polycystic ovary syndrome, or could it be something else? And you definitely want to make sure that they don't have these other things. So if they've got a really big abdominal fat mass with striae and very skinny legs and find it hard to get up from a chair, you might think, oh, this is Cushing's syndrome. Congenital adrenal hyperplasia can look very much like polycystic ovary syndrome. An androgen secreting tumour, as I said before, will have a rapid onset and typically virilization with scalp hair loss. But hyperprolactinemia can mimic this, and hypothalamic amenorrhea is a real trick in some circumstances. And hypothyroidism. So these things can be easily screened for, and you just need to be considering it if you're thinking if a woman has Pcos. So I just thought it was worth going through hypothalamic amenorrhea, because those women can have polycystic ovaries and some people can get tripped up by this. But these women, rather than having an overweight BMI, will be underweight. They will have a low caloric intake or restricted diet, and some of them might have tried to lose weight having been overweight and might have had a rapid weight loss or gain particularly. But regular intense exercise is a typical part of this cohort, and a type A personality, perfectionist, anxiety, often doctors' daughters or lawyers' daughters. Some of you might giggle hearing that or sigh. Stress, so they tend to be stress heads in work, study and life. And what the difference is, you'll see a low FSH or LH or blunted, and a low or suppressed estradiol level, and that's a real difference with polycystic ovary syndrome. But you do often see the polycystic ovaries on an ultrasound, and this is a safety valve where the body doesn't think it's going to support a pregnancy, so it shuts off the messages between the hypothalamus, pituitary and the ovary. So very different from the insulin resistance problem that we see in Pcos. So these are the typical tests I do on the left, and it's tricky because depending on your lab, you might not be able to do a sensitive total testosterone, but you should be able to access a testosterone assay that they would use in children where the levels are low, because remember, female testosterone levels are typically a 10th to a 20th of male levels. So it's hard to measure testosterone accurately. You do need to measure SHBG, sex hormone binding globulin, as well, because that will affect the active or calculated free testosterone. So don't measure a direct free testosterone. In women, they're just not worthwhile. But if your lab does both total testosterone and SHBG, you'll either get a calculated free testosterone or a free androgen index, and that's useful as well. Estrogen I measure really to rule out other things. LH and FSH, there is a nice sort of thing with a ratio of LH and FSH. Usually FSH should be more than LH, but will depend on where they're at in the cycle. But in polycystic ovary syndrome, it tends to be reversed, and the LH tends to be more than the FSH and more than a 2-to-1 ratio. So that's another part of evidence rather than being terribly useful, just part of the evidence. I do a TSH, prolactin, and prolactin can be a little elevated in this syndrome too. I always do a 2-hour oral glucose tolerance test with insulins, and that's hard when you've got a 16-year-old in front of you, because you might do a fasting glucose and insulin and totally miss it, but the response to glucose and that load, you might be really surprised to see insulin go up into the hundreds, and even to see pre-diabetes on that 2-hour level. So I always try to do it unless there's needle phobia, unless there's other good reason not to. I always do a fasting lipids to see where they're at baseline, and pelvic ultrasound will depend where they're at. We don't do it within 8 years of menarche. That's from those evidence-based guidelines. But if you're really worried and think, oh, this is an explosive onset, I think they might have a tumour, you know, they're virilized or whatever, at whatever age, you do your ultrasound. You don't want to miss something. And the other value of an ultrasound, if they haven't had periods, you just want to make sure they don't have endometrial hyperplasia or thickening. So I think if you can err on the side of doing the ultrasound, I don't think there's any harm. But of course, if they're not sexually active, you'd want to do an abdominal ultrasound rather than a transvaginal one. And the limitation there is if they're quite overweight, you might have a limited picture, but you do what you can. On the right, I do a beta-HCG if I'm thinking, oh, they could be pregnant. Depends on who they are and who they've been with. The 17-hydroxyprogesterone is useful for ruling out that non-classical congenital adrenal hyperplasia. Sometimes if I think, oh God, they've got an enormous tummy and they've got skinny sticks for legs and they look like they're Cushingoid, I'll do that 24-hour urinary free cortisol, but it's not necessary to do it on all. I will do the DHEAS and the androstenedione just to really make sure that in case it's a dodgy testosterone assay, and just to make sure that the picture's consistent, and it is a good marker, more the DHEAS rather than the androstenedione. There are ethnic variations here. Milder phenotypes in some Caucasians, higher BMI, especially in North American and Australian and New Zealanders, more severe hirsutism in Middle Eastern, Hispanic, Mediterranean women. And some women may be hirsute and not have this syndrome in those cultures, in those ethnicities. Increased central adiposity, insulin resistance, diabetes in Southeast Asians, lower BMI and milder hirsutism in East Asians, and higher BMI and metabolic features in Africans. And I think we're all seeing in a multicultural society many different types of people from different backgrounds. So just to be aware of those differences. So we think here that there's a genetic tendency, and often if it is a girl in her teenage years presenting, she'll often come with mum, and you can often see, you can look at mum and you can look at girl and you think, well, I know where this is coming from. So a genetic tendency is there, and then lifestyle things. So remember when I said that girl had stopped fencing at school, she'd stopped her activity, she got her license, etc. They tend to do less activity, gain weight, and we think when the weight is a higher weight that is healthy for their height, so a higher BMI above 25, then that's when these things can happen. So lifestyle and obesity. With those things we think, and there's no clear understanding here, but we think those things change the way insulin is created. We think there's too much insulin, it doesn't work very well, but it does tend to work on the ovaries such that it makes the ovaries change their follicles development. Their testosterone levels will typically go up, but not always, and that will lead to the symptoms: excess body hair, acne, their risk for diabetes and heart disease, and the polycystic ovaries that you'll see on an ultrasound, and the presenting factor of infertility for some of those women. And then, of course, there are spin-off effects at the bottom. So these are the things a woman will come to you with, and they like you, but a teenager might not come to you for other reasons, but they will with acne, they will with weight gain and trouble losing weight, or extra facial and or body hair. Thinning scalp hair, of course, you need to ask about that. Irregular periods and fertility problems. They're all the type of things that women will come along with, but also emotional challenges. So you need to be asking about those. Anxiety and depression, that's pretty widespread at the moment anyway, and body image challenges as well. So it's a sort of a package, and you need to identify one and then sort of think of the others. But we're also thinking of future here, because this is, as I said, a chronic disease with implications for the future if we don't sort of get onto it in the early years. So there are higher risks of gestational diabetes, impaired glucose tolerance, obesity, increased cardiovascular disease risk markers, obstructive sleep apnea because of the weight usually, endometrial cancer. So if there aren't periods for a long time and there is endometrial hyperplasia, that's when cancer can develop, and that has been well documented in this syndrome. Infertility and depression and anxiety. So the management areas are many, and it's a sort of a nice paradigm, and you can really work well with these women to really change these. It just takes a little bit of energy and enthusiasm and getting through psychologically to them so that they can make a change and so that they can understand, because it is a complex sort of set of understanding to get to the end point that they might come with, which is the periods or the acne or whatever. So lifestyle is very important. I'm going to take you through that. Management of what they're worried about, the excess hair, acne, the scalp hair loss. You can't abandon those things, because if you do and focus on other things, they won't come back, because what they came to you for was the excess hair growth, and you've got to look at the excess hair growth and help them with that. Menstrual cycle regulation and fertility, metabolic syndrome, insulin resistance, sleep apnea, and of course, mental and emotional health. It shouldn't come last, but with this, it has traditionally come last. So we've got to try and bring it up there. And you like team effects, and I know you've got good teams out there. We all need this. You're the mainstay of this. I think that you are the person on the ground. Studies have shown that you are trusted, and that people want to come to you for advice that they trust rather than the internet, believe it or not. But it is a team effect, and we really need everyone to help. Not everyone who's an endocrinologist or a gynecologist is an expert. You might need to refer off for expert advice, and you just need to find someone who is an expert and not refer off to someone who doesn't really know much about it. And I have seen specialists really not know much about this, and as I'm sure you have as well, it is tricky. The primary management here is lifestyle, particularly if there's weight excess. Healthy eating is very easy to say, hard to do. Regular physical activity is also easy to say, hard to do. And weight management is extremely hard to do. But in this syndrome, losing weight can have a real impact on the symptoms that they came to you with. So it's important to reiterate that if you do this at this point, then the things that you worry about will be improved. And we need to sort of get some strategies, and it's a lot about psychology, and it's a lot about trying to put the energy in and trying to understand that person in front of you and see what might work for them, and not give up. You're not allowed to give up until you really had it, and then you can give up and let someone else do the challenge. So healthy eating, there's no absolute one strategy here. We need to focus on weight loss if there is weight excess, or prevention of weight gain. Either one is good, and we want to reduce those longer term risks of diabetes and cardiovascular disease. So small and frequent meals to maintain that metabolic rate would be ideal. Grazing would be a good level. Moderate serves of protein, high fibre, low GI carbohydrate, plenty of vegetables, healthy oils, etc. And avoiding processed food, takeaway foods, easy food and cheap food. And I know this is very easy to say on a piece of paper, but to get someone to do it is really hard. You need to try and work with a dietitian if you've got one, and try and get those messages in. And I think they are a lot better at school at getting those messages in, certainly from what my daughters have told me from learning things during health at school. So physical activity is really important, and you can't give them a terrible goal that they're never going to do. But if they want to affect a change, and most of because they want a change, we need to be doing something. And I always say, I want you to be doing 30 minutes a day of something that makes you puff. And I know that's terribly hard for busy people to do. It just, again, needs to be something that they can do, something that's not expensive, something that you can do even in lockdown if that happens. And we just like to be doing something, and they do say 150 minutes per week of moderate intensity activity. There's no one right way, but you can do a 10-minute bout, you can do a stair climb, you can, park your car further away at the supermarket. There's every bit of exercise counts, and you've just got to try and hammer that in. So weight management. It is important to do a weight. You could do a waist circumference too, which would be brilliant, but I know you're time poor and you've just got to do what you can. And we don't want to make the weight such a terrible focus that the women just get disillusioned and sort of abandon plans. And we need to sort of encourage everything. So a healthy lifestyle, we need to get every support. So if the mum comes in with the daughter, I try and make it the family problem and say, let's do all this together. Let's make it a family problem. Don't point the finger at your daughter. Let's do it together, even if it's exercising together, dietary planning together, etc. A psychologist might help if you've got those services. An exercise physiologist is brilliant for exercise, and a dietitian are brilliant. But the key message at the bottom in pink, even a 5 to 10% loss of weight will assist symptoms, will help the insulin resistance, and will help the symptoms at the end and improve fertility. So if you're 100 kilos, that's up to 10 kilos, and that is doable. I always believe that that is absolutely doable. The management of excess hair, there's lots and lots and lots of strategies. Waxing, threading, electrolysis, laser hair removal, definitely. If there are darker pigmentation, they might need IPL, and I think that definitely dampens down excess hair growth. It won't get rid of it altogether, but definitely very useful. Finiqua used to be available. It's currently not available to get, but that was an expensive option, but some ladies found that very useful. It's not a depilatory cream. It changes the way the hair grows in the skin. The pill, very useful. Any pill is useful. And anti-androgens if we can't use the pill or want to add it to it. So spironolactone, but if they're looking at fertility or if they're of reproductive age and may get pregnant, you don't want them to be on spironolactone because that can harm a developing fetus. Acne, you do your normal standard topical measures for acne. You can use, of course, antibiotic treatment, etc. The pill will be very useful. Spironolactone can definitely be useful as well. So there's no one right approach here. It's got to be the right approach for the woman and what she'll take and what she can manage and what won't lead her to problems such as spironolactone and pregnancy. The irregular bleeding, really, if you ovulate, that problem should be fixed. Well, hopefully fixed. A weight loss of 5 to 10% will help with that. The pill obviously will help that. It will provide contraception. And because the pill will sort of go against the insulin resistance a little, we do want those lower dose pills to be used as much as possible, especially when there's weight excess. You're getting the added benefit that there'll be a benefit from the hirsutism and the acne as well. I do use a lot of metformin, and that's particularly, I suppose, if we're looking at fertility or if we're looking at weight loss or we can't use the pill. Metformin, we think, is cheap and easy. It just affects the insulin resistance, which we think underpins this syndrome and will improve ovulation and cycles. But you do need to tell someone of reproductive age, if they're on metformin, they will have an increase in their fertility. So to be very careful if they are sexually active and don't want a baby. That would be a bad thing if they get something they don't want. The progestogens can also be useful. The Mirena, the NuvaRing, of course, can, and you can have an intermittent progestogen to just give a bleed every 2 to 3 months as well. That as long as they're not just sitting there with no, amenorrhea for a long time and potentially getting endometrial hyperplasia, we do want to have some form of bleeding. So unless the Mirena is in, and then you're allowed to not have bleeding. So insulin resistance, you know what insulin is. We think that there's too much insulin produced in this syndrome and it's not effective as it should be. You can get it in lean women. I've been surprised. I've done glucose tolerance tests even in lean women, and I've been really surprised that insulin levels can be really up at the 2-hour mark. It's definitely worse with obesity, and we really think that this underpins the whole of polycystic ovary syndrome. You know about metabolic syndrome. I think you're faced with people every day that come to you with increased blood pressure, high blood sugar, increased waist circumference, and high triglyceride levels and low HDL. And as you know, that increases the risk of cardiovascular disease. So you want to really get onto this if you've got a 20-year-old in front of you with these problems. That's a killer of a third of Australian women, and it would be good to get onto that. The younger, the better. As I've said, I've talked a lot about metformin already. It definitely can help with regulating ovulation. It will help fertility in some, and it will help in some to lose weight. It's variably tolerated. It can be a bit rough on the tummy. I always start at a very low dose of 250 milligrams daily with food, and then I give them a schedule to increase that to 250 milligrams BD after a week, and then 500 milligrams in the morning, 250 milligrams at night after another week, and then 500 milligrams BD, and gradually increase that to a gram BD. If they don't tolerate that, then I would go on to the extended release metformin, and that's easier to just take 1 gram or 2 grams at night. It's a bit kinder to the tummy. So you do need to tell them about, and also about alcohol excess. If they're binge drinking, metformin can increase the risk of lactic acidosis, which is very rare. And I just do a real go slow with this, because if they start a big dose, get diarrhea, stop it, then you've abandoned and we've lost a good treatment. And I just go really slow and just do it very gently. The key messages for fertility. So this is a really brilliant strategy to intervene here. Because Pcos limits fertility, but don't tell a Pcos lady when you've just diagnosed her, just say, oh, you're infertile. I've had that message, and I'm not saying any of you did it, but those messages have come about historically throughout my career. It can be treated, and most women with Pcos will conceive. They might need some assistance though, and especially if they're over 35. So if they're in a relationship, I usually tend to try and say, well, get looking at your family before the age of 35, because if you need assistance, that's going to be trickier after 35 years of age. And a BMI of more than 30 limits fertility, and women who want to conceive will take action. It's like women who want to get married, or women who are having an engagement party or 21st, they will take action to look good in the photos, and you will usually take action if you want to conceive. And the other thing is for fertility, if we're making sure weight is controlled, those risks of gestational diabetes and pregnancy complications are also limited, and that will get a woman to action as well. So what the evidence-based guidelines said was that letrozole was the first line pharmacological therapy for infertility. I don't see that in practice much, and I don't know if you see that. I'm not saying it's not to be done, but I see more clomiphene treatment or Clomid, and I've seen, I don't prescribe clomiphene, but metformin I certainly prescribe, and then I'll send them off for fertility advice. But that's what the evidence-based guidelines says, that letrozole's first line, and we can easily start metformin, that's very easily. And if there's no action with fertility, definitely getting some fertility specialist advice is definitely recommended in this scenario. So mental health, there's an increased frequency, and this is all from studies, of depression. Look at that, it's up to 64%. Anxiety, up to 57%. Bipolar disease and eating disorders. And that's, considering these things are rampant rife anyway, we just need to be aware that labelling someone with a chronic disease, and maybe when they look in the mirror and they've got acne, excess hair, and they're overweight, of course these things are more easily going to happen. So we need to just make sure that these women are supported in whatever way we can. And again, I know that depends on what services you've got about and your time constraints as well. It's all a very tricky game with wanting to do everything, but not being able to do everything wherever you are. It's tricky. So we want to detect women early. We want to reduce the risk of diabetes and heart disease, and we want to manage weight. But as I said before, preventing weight gain is pretty good. Losing weight if they're overweight is better, but preventing weight gain is really good. If they're gaining a kilo a year, in 10 years, that's 10 kilos. In 20 years, that's 20 kilos. We want to improve fertility, emotional well-being, healthy lifestyle, and those androgenic effects that they will come to with you, because that's what really the majority of these younger girls will come. The ones in their 20s and 30s might come with fertility issues. There is a lovely health professional tool that's been extremely, it's gone through so many revisions and every word has been carefully looked at. And it's a nice fold-out tool you can have in your drawer, but it's also available online, and it gives some nice guidelines with key goals and key things to look out for, and also investigations. So this is from Jean House. It's on our website, and you can easily gain access to that. There's also some webinars and there's some e-learning modules, and I think we've just launched one. If you're a health professional that receives the Jean Howes updates, I think that was just launched very recently. And of course, attending a webinar like this, well, you won't need that now, but I know there is some webinar material on there, and it just reinforces the messages there. But there are some good resources out there. And there's some good resources, including multilingual fact sheets. There's one over there in Mandarin, I believe, on the right. And these are things that women may find useful. And there's also some very worded down. So when women look at literature, the average age of reading literature will be a year 8 reading standard, and these are trying to do that, but there's one that's also just slightly below that for those who might struggle with these messages. So we've tried to cater for everything, but if you think it's not there, let us know, and we will try again to cater for another gap in the information that we've tried to provide. I'm going to point you in the direction of those evidence-based guidelines again, but that I think the summary is more useful, and I think my messages are a summary of that. And I'd like to thank you for being so good to have me and for listening through, if you've managed to sit through everything. This is a really important syndrome. With a bit of energy and enthusiasm, you can do really well with these ladies. I've had some really great progress this year with some of my Pcos girls. They've lost stacks of weight, they feel great, and you can see it on their face, and it gives you a real thrill. But thank you for having me. Delighted to speak with you all, and I believe now we might be having some questions.
Thanks, Sonia. First question, what about intermittent fasting as a strategy for reducing exposure to insulin?
Yep, I love it. Do you know what? It's whatever strategy works. So if there's money, light and easy, Jenny Craig, they will work. Weight Watchers works. Intermittent fasting works. Lowering carbohydrates is a really good strategy, I think. The things like bread, pasta, flour, noodles, spaghetti, etc., rice, those things will stack weight on some individuals. There's no one right strategy. It's got to be something that they can do, something that they don't hate, and something that they can stick with, or at least do it in bits and pieces. And intermittent fasting is well versed, well suited to that. Yep, good question.
Thank you. Next question, what triggers you to commence metformin?
It really depends. Some can't tolerate the pill or didn't want it, or whatever cultural reasons can't have it. Weight excess. If I do the glucose tolerance and see those high insulin levels, I know it'll work better. It really will depend on the individual, and especially if they're looking at fertility, I will be more keen to use that. There's no one right reason. It's not going to do a lot for excess hair, acne, and those sort of things. I think the pill's better suited to those. But certainly for those metabolic things, definitely, and for fertility, it's an easy and cheap thing to do. And in some women, they do really, really, really well, and they continue it for years, and it's pretty harmless.
Thanks, Sonia. There's no questions at this stage. If you do have a question, quickly pop it in the question box while I just say a few words. Just want to thank you, Sonia. We're so fortunate to have had you speak on this topic and sharing your expertise. It was terrific. And thanks also to Jean Howes for their partnership in this. We're running a women's health series, and this is part of our women's health series. Our next one is in February, I think it's the 16th, and that's on endometriosis. And then I think we'll be following up on one menopause, I think, in the next couple of months after that. So it doesn't appear to be any more questions, so we will finish the webinar now. Thanks again, Sonia.
Delighted.
Thanks, everyone.
Nice to see everyone. Take care. Good luck. Bye.